So good morning, good afternoon, or good evening based on where you are joining us from today. Welcome to today's webinar. My name is Laura Ceci Galanos. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization. We provide stroke education to health professionals worldwide, and it is with great pleasure that we are hosting this educational activity today. We are exploring the latest evidence and approaches in optimizing antiplatelet therapy for stroke patients. And for that, we are very lucky to have two exceptional speakers who will be sharing their expertise on the topic in a few minutes. A special thank you today goes to Genedrive for supporting this webinar with an unrestricted educational grant. And of course, as always, to the over 600 of you who registered for today's event and who are ready to learn more. So let's dive into our housekeeping rules very quickly. Before I introduce today's chair, we welcome any questions that you might have throughout the webinar. We have a dedicated Q&A discussion at the end, but we kindly ask you to use the Q&A box for those so that they can easily be seen in one place. So not your comment section, but the Q&A box. You can, of course, use the chat box if you want to say hi, tell us where you're joining us from, or leave any comments, feedback. A reminder that this webinar is recorded, like all of our webinars, and the recording link will be sent out automatically to all of you via email shortly after the webinar. It will also be uploaded on the World Stroke Academy site and our YouTube channel, so you can also reshare it with your networks and rewatch it whenever you want. And lastly, we kindly invite you to fill in the evaluation survey at the end. This really helps us to get your feedback, to understand what it is you're interested in, but also gives you a chance to claim your certificate of attendance for today's webinar. Now, without further ado, I will introduce today's chair, but also our moderator, Professor Simona Sacco. She's a professor of neurology at the University of L'Aquila in beautiful Abruzzo, Italy, and she's the current president of the European Stroke Organization. Simona, the floor is all yours, and thank you for being here.
Thank you, Laura. Thanks a lot for this nice introduction. And hi, everyone, and welcome to this webinar. I wanted to thank the World Stroke Academy for organizing this webinar and for selecting really a very interesting topic. We will discuss today how we can optimize antiplatelet strategies in stroke care. And we know that this is something very important in clinical practice. We sometimes see patients who experience a stroke and they are already taking antiplatelets. And so here the question is, what shall we do for the future? And we know that we have patients who are at particularly high risk and for whom we would like to do more. And so you will learn more in today's webinar. So without any further ado, let's start. And it's my pleasure to introduce the first speaker, Professor Daniel Bezerra, neurologist and epidemiologist from Rio de Janeiro, Brazil, beautiful city. And the topic of the talk is current indications for dual antiplatelet therapy in acute stroke patients. Please, Daniel.
Do you see my slides?
Yes, we can see.
Thank you very much. I'm deeply honored for the invitation and the opportunity. Thank you so much. So let's talk about. Okay, so this is my disclosures. Okay, so we're going to discuss about dual antiplatelet therapy after stroke or TIA. So the first question is it worth in the long run? So I would like to remind you firstly about the Charisma trial, which is a trial which included patients very similar to the Capri trial. So patients were those with very high vascular risk factors. So they had previous CIA, stroke, MI, etc., and peripheral artery disease, and were randomized for the long run using either aspirin or aspirin plus clopidogrel. And when you in the follow-up, all these patients, you can see that there is a non-significant decrease in the vascular events. So there's not an increase in severe bleeding along the time. So, and the second study that I would like to remind you is the MATCH study, which randomized patients by using clopidogrel compared to clopidogrel and aspirin. So when these patients were compared, so in the long run, you see that there is no significant decrease in vascular events, and also there is a clear increase in life-threatening bleeding, as you can see here. And the third trial that is very important to remember is the SPS-free trial, which randomized about 3,000 patients with lacunar stroke seen by MRI, less than 2 centimeters, an acute stroke, and they were randomized to clopidogrel or placebo, and both arms received aspirin. And when you take a look and see these patients in follow-up, you see that you do not decrease the incidence of the recurrence of ischemic stroke in these patients. There is no significant decrease, and also there is a clear increase in hemorrhage, and also increase in vascular death and hemorrhage. So especially in patients with lacunar stroke, it's not a good practice to keep 2 antiplatelets compared to 1. So that's what happens in the long run. So that's what happened here. And also there is increase in gastrointestinal bleeding. Okay, so when we take into account all these trials, and here we are SPS-free, we're Profs, but when you take into account all these trials, you see that there is no benefit in the long run of keeping 2 antiplatelets compared using only 1, and is also accompanied by two recommendations here in the first on the right. In the top right, the American Heart Stroke Association, and here from ESO. So both guidelines do not, neither of the guidelines recommend using 2 antiplatelets indefinitely in these patients. So what are the short-time effects? So that's the main object of this trial. So the first trial that should be remembered is the CHANCE trial. So CHANCE trial randomized about 5,000 patients who had NIHSS less than 3, so they are mainly TIA or minor strokes, and had the ABCD square or 4 or more points. So people were regarded as high risk for recurrence. And they were randomized to take 2 antiplatelets, so aspirin and clopidogrel. There is some design but a bit difference, but the randomized to take 2 antiplatelets comparing to just 1. And in the long run, when for 21 days, so there was a loading dose of 300 milligrams, and the people were followed up for 21 days. And then when you see that, in the long run, you see there is a 32% decrease in the rate of ischemic stroke recurrence, and there is no increase in hemorrhagic stroke. And you can see here in this graph, which is very important to notice, is that most of the events do happen very, very, very early. So here we see the difference, and afterwards, the 2 curves are essentially parallel. So the second trial that should be remembered is the POINT trial, which randomized people very similarly designed, randomized to use clopidogrel plus aspirin compared to aspirin alone for 90 days. And this trial, and people were given with a loading dose of 600 milligrams of clopidogrel. And this trial, the trial was stopped by the DSMB due to bleeding. There was a 32% relative increase in bleeding. But you see that when people took a look at the reducing events, there was a 25% reduction in composite events in this population. So you see that most of the events of major hemorrhage happens along the time. So when you follow up these patients, and all the events, the main difference is really very here at the beginning. And the third trial that should be remembered is the INSPIRE trial, which is very similar to the 2 I just commented. And there is one arm of this trial, which was studying specifically the combination of clopidogrel and aspirin compared to aspirin alone, up to 72 hours after stroke or TIA. So they're very similar design and also very similar results. So you reduce the early events by 20% here, a little bit less, and also there is a very mild increase here in hemorrhagic stroke. When we combine all these trials together, these publications from last year, you see that the sweet spot of the best moment to keep 2 antiplatelets and only compare it to just 1 is for about 21 days here up to the 3rd week. After that, there is no benefit in keeping 2 antiplatelets in the long run. So there is a 3rd trial that should be remembered. 2 more, the Socrates and Thales, which randomized ticagrelor. So the first one is ticagrelor compared to aspirin, and here is ticagrelor plus aspirin compared to aspirin alone. And here you see that you do decrease the rates of ischemic stroke, but here you do increase the rates of severe bleeding. It will be discussed a little bit later. And the CHANCE-2 should be also remembered and will be discussed further in the next talk. The CHANCE-2 is a trial that randomized people who had a mutation. So since clopidogrel is a prodrug that is converted to an active drug, so some people do not have this capability of conversion in the active drug that they should be resistant to clopidogrel. So that should be talked a little bit later. So in these people who have this resistance, and Professor Newman will talk furtherly, you see that when you compare both drugs, clopidogrel plus aspirin compared to ticagrelor plus aspirin, the combination of the latter is much better. So you have a 23% relative risk reduction. So how can we understand this difference? So that's the main objective of this talk. So there you have to understand that the first thing is to understand that the combination of the balance between early recurrence risk and also the hemorrhage risk. So when you take a look at these curves, as I told you, you see that most of the events of recurrent stroke do happen very, very, very early. So here from 0 to 7 days. So very early in the first 24, 48, or maybe 3 or 4 days, you have the difference in the curves. But after about 7 days, you see that the 2 curves are essentially parallel. So there is no difference at all. That there is some difference, but there is not a major difference between the 2 curves. And after 21, 30 days, the curves are essentially parallel. So there is no difference in the rates, the reducing rates of the events in these patients. And you see that if you take a look at the curves of the hemorrhage curves, you see that there is a slight increase and progressive increase along the time. But very early from the beginning, people do increase the rates of hemorrhage, and here compared to the other curves. So there are 2 different slopes. So if you do intervene very, very, very early, you do reduce the rates of recurrent ischemic stroke in these patients without significantly increasing the rates of hemorrhage. So here's another example. So there is a population-based study of people from Oxford's vascular study, and you see that most of the events of stroke after a TIA do occur in the next 24 or 48 hours. Of course, there are people who might happen later, but most of the events do happen very early here. The same thing here, you can see in this very famous study on which the ABCD score was derived in California. So when you combine all the studies, you see that there is the risk of very, very, very variable in the long run. So the next question that should be understood regarding the early recurrence risk is the ABCD square. So what is ABCD square? So ABCD square is a score that was derived from this famous study in California, who looked at patients in the emergency room and looked for variables that were associated with increased risk of recurrent stroke within 90 days after admittance of these patients. So they selected all these variables that were described in here, and the score was so the first score was an ABCD score, which was combined with the Oxfordshire cohort, and they divided the first score with ABCD, and laterly the score was updated to the famous ABCD score, which regards for age, blood pressure, clinical features, and each of these we have some points that you can look here, and the duration of the symptoms, and diabetes, I'm sorry. So if the score is equal to or greater than 4, the patient's estimated to be a high risk. So this score was validated in a number of cohorts. So I would like to remind you, especially of the TIA registry, which is published in the New England Journal in 2016, where you can see in this score, in the upper right corner here of these pictures, there are many validations here. There is a clearly dose-response effect. So compare with people who had a score from 0 to 3. So those with 4 to 5 or 6 to 7 have a really higher risk of score of recurrent stroke risk in the long run. So the first thing you can, so if you want to look patients who have a high recurrence risk, the first thing you can look is the ABCD score. And the second thing I'd like to mention is atherosclerotic vascular risk disease. So here you go. So I always like to see this slide. So these are two population-based studies. So first one is in the United States, in Minnesota, although there are slides, this population is very were taken in the 80s. All these data is very, very consistent in the literature. And when you take a look at the time after stroke, so if you take a look here, the risk of recurrent stroke, there is a very, very different risk regarding according to the etiology. So while people with atherosclerosis with stenosis, and this time this was regarded people who had a greater than 50% carotid stenosis, usually examined by Doppler at that time, you see that most of these people do recur. We have 85%, 8.5% recurrent risk every 7 days, and nearly 20%, so 18.5% in 30 days. At 90 days, you have a little bit more than 20% recurrent risk, which is very, very, very much large. This is very, very strikingly different with comparative people, for example, with lacunar infraction, who had 1.4% recurrent risk, and it's nearly stable from 7 to 30 to 90 days. And you compare that, and very, very similar results were found here in people in the United Kingdom, as you can see here. Large atherosclerosis at 7 days is 4%, at 1 month 20%, and at 3 months nearly 20%. So 20% is huge. So people with atherosclerosis vascular disease, up to 1 in 5 will have another stroke after a minor stroke or TIA. So the first thing you should remember is if someone has a atherosclerosis with stenosis, here I'm sorry about carotid stenosis, for instance, you don't, it doesn't matter what was the ABCD2 square. So there is no incremental value in knowing this score. So if someone has a TIA and you see that there is atherosclerosis with stenosis, you do know that this patient has a very, very, very high risk of recurrent stroke, regardless of the ABCD score. So there is another study which shown exactly the same thing here. So, and this also is true for people with intracranial stenosis. So there is this large population-based study, very interesting. And you see that people with intracranial stenosis do have a very high risk of early recurrence stroke, and also have a very high risk of increased stroke in the long run, even 7 years after a follow-up in these patients. So the fourth thing that I would like to mention is the documentation of infarct on acute neuroimaging. So it's very interesting to look at this study. I really like this one. So here there is a study which we take a look at DWI, which is much more sensitive to taking a look to examine people with ischemic stroke, so it's much more sensitive. So, and you can take a look first in the left here. So when I take a look at people with ABCD scores regarding which, so 0 to 3, 4 to 5, and 6 to 7, and these people had a DWI positive, so this person had infarction. So when you take a look here, there is a clear dose-response effect. So people with ABCD scores 0 to 3 had a 1.8%. And if you have 4 to 5, you do increase from 2%, nearly 2, to 7.5. That's huge. And if you have 6 to 7, you do increase from 12 to 12.5% recurrent stroke risk at 7 days. But take a look at the right side. So people here, for example, if you do have a negative infarct, so DWI negative, you see there is no dose response at all. So it doesn't matter, nearly doesn't matter the value of the ABCD scores. It's 0.1, 0.7, 0.4. So it doesn't matter. So if the patient has not an infarct, you do see that there's a clearly less risk of recurrent stroke compared to these people here on the left side of this table. So, and also there is a prognostic value regarding this, even in the long run. So people in the Oxford Baxter study, nearly 10 years after stroke, after TIA, I would say, and when you take a look at it, people had DWI positive, you see that there's a clearly higher risk of increased recurrent stroke in these patients, or increased stroke in these patients, even 10 years after the event. Okay. So the fifth thing that I would like to mention is the ABCDI free. So here we do combine all this information that I just mentioned before with the ABCD square. So you also include another thing, which is a clinical thing, which another issue, which is dual TIA. So someone who had a TIA prompting medical attention plus at least another way in the preceding 7 days, which does make sense. So someone who is recurring. And also you take into account all the variables that I just said before. Someone has over 50% stenosis, and also you have an acute DWI positive. So when you take a look at all this data, you see that the ABCD3I has a much higher area under the curve compared to the classic ABCD2 square. So if you take into account all these variables, you do have a better classification of the patients that are likely to recur after stroke or TIA. So you have also two things that should be mentioned. The first thing is intracranial stenosis. So intracranial stenosis was mainly studied, very interesting to mention, in the SAMPRESS trial. So I'd like to remind you the SAMPRESS trial was a trial that randomized patients. This was funded by the NIH and was randomized patients in both arms, randomized patients to receive a wingspan stent or not, or medical attention. But I would like to mention about the medical intervention. So the medical intervention in this study was everyone would receive aspirin plus clopidogrel for 90 days. So we don't know exactly regarding these people whether we should keep these patients with less than 90 days or not. But they also received a very, very aggressive medical management. So everyone would have their blood pressure clearly reduced by less than 140 or even less than 130 if these people are diabetics, very aggressive LDL reduction. And also there is a clearly lifestyle modification program. So people will quit smoking, start exercise, they would be monitored for the exercise. And that's how they do it. So when you take a look at these patients in follow-up, you see that even after 30 days, you see that the probability of a new stroke was 5.8% in the patients with the medical managed group compared to 14.7% in patients who were treated with stenting. So nearly 3 times higher risk if you do stenting. And also the risk is clearly higher even at 1 year in patients who had stenting compared to medical management. So if you take a look here, 5.8% is really much less than you would expect only on the population-based studies. So it's very important to say that medical management, including aspirin plus clopidogrel, was seems to be very effective. There's a high efficacy for reducing events in these patients. So, and that reduction was also sustained even after 2 years in this long-term follow-up study. So the final study that I'm about to comment is the cilostazol and CSPS.com trials. So in this trial, patients with stenosis, either intracranial or extracranial stenosis, were treated by using aspirin or clopidogrel, were randomized to take cilostazol 100 milligrams twice a day. But this is an open study, it's not double-blind, or monotherapy. So there is no placebo. And when you see these patients in follow-up, you see there is a nearly 50% relative risk reduction. So the hazard ratio is 0.5, and there is no clear increase in bleeding in these patients compared to these two. So since this trial it was open, you do reduce a little bit the level of evidence, but this was included in the American Stroke Association guidelines. The addition of cilostazol 200 milligrams a day to aspirin or clopidogrel should be considered in patients with 50 to 99% stenosis of major intracranial artery. Muito bem. So thank you. So takeaway message, you can use aspirin plus a P2Y12. You should not never use indefinitely after 90 days. Targets which are no. So 21 days for you should to use clopidogrel plus aspirin. So if you take into account the chance point and inspired trial, you can consider using 30 days if you do take into account the Thales trial, as we will talk in the next talk. I think so. And also 90 days, you should consider in 90 days for intracranial stenosis as indeed in centuries. So you can see high risk of recurrence for ABCD2 square 4 to 6, people with large vessel stenosis, minor stroke, or recurrent stroke, recurrent symptoms. And the final things is whether we should include aspirin or clopidogrel in addition to losazole in people with high-grade stenosis. Thank you very much.
Thank you, Daniel. Thanks a lot for this excellent talk. A lot of interesting information. We will have the discussion at the end of the session. And so to those who are listening to this webinar, please add your questions to the section you can find below. And now it's my pleasure to introduce the next speaker, Professor Bill Newman, who is a professor of translational genomic medicine at the University of Manchester and a consultant in genomic medicine at Manchester University NIH Foundation Trust. The topic of the talk is the importance of genetic testing of CYP2C19 in stroke patients. Please, the floor is yours.
So thank you very much. It's a pleasure to join everybody today. Thank you for the kind introduction. So just to disclose, I am a co-founder of a company called Farva Health. I've received funding from various organizations for my work over the last 24 months, and I work closely with the company Genedrive, and I will describe some of our work with them, recognizing that there are other companies that work in this space. I should declare that I am a clinical geneticist rather than a stroke physician, but I think that improvements in care absolutely emanate from when different health professionals work together collaboratively. So we're all very clear that clopidogrel, as we've heard earlier, is a prodrug. It's absorbed as an oral agent through the intestine, where it's then passaged through the liver for its first phase metabolism, and that happens via a number of cytochrome P450 enzymes, but particularly one called CYP2C19, which is the major enzyme in its conversion to its active thiol constituent, which inhibits platelet activation and aggregation. So what we're hoping to cover over the next few minutes are just understanding how this genetic information can help us to understand how clopidogrel can be effective. And it's really important to stress that nearly all of the evidence around genetic testing for clopidogrel is based on when you start the medication. It's not based on patients who have been on that medication for a long time. Hopefully, I will be able to describe the difference between a genotype and metabolizer status and how it's important to understand some of this language. Most importantly, I think understanding at what point in the clinical pathway this pharmacogenetic testing needs to be undertaken and when the results need to be available. And then we can explore when you might want to use a point of care test to generate that information, or when you might want a laboratory-based test. So clopidogrel is clearly used in lots of areas of medicine. It's used for patients with acute coronary syndrome, for percutaneous coronary intervention, patients with peripheral vascular disease. But as we've heard so eloquently from Daniel already, it's used extensively in stroke medicine, and particularly for this prevention of recurrent events, either after a minor stroke or a transient ischemic attack. And the reason for that is because after one of these events, clearly, as you're aware, patients have a very high risk of a recurrent event with associated morbidity and mortality, up to 1 in 5 patients in the first year and 1 in 3 patients over 5 years. And there are a number of reasons that we've seen a drop in these recurrence rates over the last number of years, including lifestyle changes like smoking cessation, people being encouraged to exercise, control of blood pressure, control of hyperlipidemia and diabetes. But antiplatelet therapy is key, and I think that's an absolute consensus from international guidelines that using antiplatelet therapy can significantly reduce the risk. I think the questions are, how do we best optimize that antiplatelet therapy? So quite clearly, we've known for a long time that CYP2C19 is important for the metabolism and the effectiveness of clopidogrel. And that we can see from advice in drug formularies and the summary of product characteristics, that patients who are started on clopidogrel are advised to avoid certain drugs that can inhibit CYP2C19. So these are very commonly prescribed drugs like proton pump inhibitors like omeprazole, or antidepressants, SSRIs like fluoxetine, and some antifungal drugs, so fluconazole or voriconazole. So when we see that there is advice around avoiding certain drugs that inhibit CYP2C19, we should be thinking whether the genetic information about CYP2C19 would be valuable also. So CYP2C19 is a highly polymorphic gene. That means it contains lots of different variants, which are generally fairly common within the healthy population. And a number of these variants reduce the function of this enzyme. The two most common variants have got particular nomenclature, particular names called CYP2C19 star 2 and star 3, and I'll explain a little bit about that in more detail. There are, however, particularly in certain parts of the world, much rarer variants which are also causing loss of function, and it may be relevant to be testing those in our care of patients. We can see but from this table that there are significant differences in the frequency of these variants across different populations. So if you look at this star 2 loss of function variant, you see that about 1 in 3 individuals in Central South Asia or East Asia carry it. That increases to virtually 2 out of every 3 individuals in the Pacific region. Likewise, we see a big number of individuals in that same region who carried this star 3 loss of function allele. These rare loss of function variants are much lower frequencies, but we see differences across different populations. And this star 17 allele I'll mention, you see at high frequencies, but this actually increases the activity of the enzyme. So for a long time, people, rather than focusing about the genetic status, they focused on what we call the metabolizer status. Does the enzyme work effectively? Does it work at a very high level, so ultra rapid or rapid? Does it work at a normal or extensive level? Or is there a reduction? We'd call that an intermediate, where a person would carry 1 normal copy of the gene and 1 loss of function variant, or a poor metabolizer, where an individual would carry 2 copies of the gene, 1 inherited from each parent, that wasn't working effectively. So there have been a number of studies that show that individuals who are intermediate metabolizers or poor metabolizers have reduced effectiveness of this conversion of clopidogrel to its active component. Unfortunately, there are no validated, easy, cheap tests of CYP2C19 metabolizer status. So we can't just take a blood sample or a urine sample and check what the metabolizer status is for CYP2C19. The only way of really doing that is through a liver biopsy, and of course that is incredibly invasive and something we want to avoid. So over our understanding of why CYP2C19 is really important is, as I've said, these genetic changes equate and can act as a surrogate for the metabolizer frequency. So we see that about 1 in 3 individuals of European ancestry have a reduced, so intermediate or poor metabolizer status, which increases significantly amongst East Asian and South Asian individuals, and at a very high level of poor metabolizers in individuals living within the Pacific Islands. So we summarized with colleagues just a few years ago the evidence that undertaking CYP2C19 genotyping would be valuable in guiding appropriate antiplatelet therapy following an ischemic stroke or a transient ischemic attack. Most of that data had emerged from a meta-analysis of retrospective Chinese studies, and that summary indicated that individuals who are intermediate or poor metabolizers of CYP2C19 had a worse outcome following stroke if they were treated with clopidogrel. And as Daniel's already mentioned, this very powerful study called CHANCE-2, which was published about 4 years ago, looked at this in more detail. So if you have an individual who is a poor metabolizer or an intermediate metabolizer for CYP2C19, what can you do instead of giving them clopidogrel? So they undertook rapid point of care genotyping using a test created by a Chinese company. They did that in 11,000 individuals. Of those, about 6,500 had one or more loss of function CYP2C19 alleles, and they were randomized 1-to-1 to clopidogrel or ticagrelor. And after 90 days, we saw a reduction in the risk of stroke in the ticagrelor arm. So that's telling us that in individuals who have been treated with clopidogrel, so rather than giving them clopidogrel, if they were an intermediate or poor metabolizer for CYP2C19, we should be using ticagrelor. But a lot of the benefit that had been seen in patients treated with ticagrelor was derived from these individuals who were CYP2C19 poor metabolizers in head-to-head studies of ticagrelor and clopidogrel. So in clopidogrel, in patients who are normal metabolizers, you can feel confident to give them clopidogrel as the first line of treatment. So there's lots of international guidelines to look at when we should be using CYP2C19 testing. So the Clinical Pharmacogenetics Implementation Consortium, or CPIC, based in the United States but has international collaborators, said there was a moderate strength recommendation that in individuals who are poor or intermediate metabolizers, you should use an alternative antiplatelet therapy apart from clopidogrel. Likewise, the Dutch Pharmacogenetic Working Group recommended that poor metabolizers should avoid clopidogrel in the context of an ischemic stroke or transient ischemic attack. And on the basis of these guidance and the evidence, lots of groups around the world have introduced routine CYP2C19 testing to inform their antiplatelet therapy in stroke patients. In the UK, just within the last number of months, there has been recommendations through the NICE, which is the National Institute for Health and Care Excellence, about when we should use CYP2C19 genotyping in the context of stroke or transient ischemic attack. And they've said that it is important to use this genotyping to determine if clopidogrel is a suitable antiplatelet in this context. So how can we test for CYP2C19 variants? Well, actually, this is a gene that it's very easy to do genetic testing for, and it's very cheap. And even if you just do a very small number of these loss of function variants, you will generate a lot of useful information. So a lot of assays just look at the STAR2, the STAR3 loss of function alleles, and then help to interpret them with this gain of function STAR17 allele. And there are lots of different tests you can do in the laboratory. Or you could consider point of care, and that's what I'm going to look at the value of those two approaches over the next few slides, because the key thing is your decision to change the medication, is that time sensitive? And as we've already heard from Daniel, the biggest risk of recurrence happens within the first 48 to 72 hours, and so the clinicians that we have spoken to have very much given us the steer that they need that genetic information as soon as possible to make sure that the patient is on the optimum antiplatelet therapy. So can you achieve that rapid within 24 hours result if you are using a laboratory-based approach? Well, the biggest challenge is your laboratory in the same building or on the same site as where the patient is? Because if you're having to transport a sample, be that a saliva sample or a blood sample, to a laboratory, that is where the biggest delay happens. The actual testing in the laboratory is usually quite rapid, but we've done some work in a national pilot study, and because the time that the result is usually available 3 to 5 days later, the patient has often been discharged or transferred to another unit, and the actual time taken to action a change in their medication is often up until 14 days, so well outside that window of 48 to 72 hours. So you can think of, well, can we use point of care testing? There isn't a lot of experience of using genetic types of point of care testing, but there are a number of different platforms that have been developed and increasingly are available. They all look to deliver a result within about an hour, mostly based on a buccal or a cheek swab sample, and they can capture information about a number of different variants in the CYP2C19 gene, beyond just the STAR2 and STAR3. And these tests are highly specific and they're highly accurate. And just in the last few months, we've published a study that has demonstrated the analytical validity of these tests. So there's no sense that a laboratory test is more accurate than a point of care test. We've looked at how does this work in clinical practice. So once you decide that you want to adopt point of care testing, you've got to make sure that you've got in place the appropriate validation and quality assurance so that you're checking that the machine is working accurately. And we've worked with the European Molecular Quality Assurance Network to set in place an accurate quality assurance program so that the clinicians can be confident that the results that they're generating are truly reflective of the patient's status. Here you can see in the picture how small the machine is, taking up a very small amount of space just within the utility room on the ward. They're very straightforward to use. Limited amount of training required, but video training can add to that. And the failure rate of the test we've seen is less than 1%. And in over 500 individuals that we've tested consecutively in the stroke unit, the hyperacute stroke unit in Salford in North Manchester, that's worked extremely well, with about 30% of individuals having an immediate change to their antiplatelet therapy. The key thing then is that you say, oh, well, you want to buy a new point of care machine, you want to do the assays, that all sounds very expensive. But when you look at the health economic evidence, the burden of having a recurrent stroke, and the morbidity and the healthcare costs associated with that are enormous. And so our health economic studies have shown that for a patient with a minor stroke, if you do genetic testing and alter their medication accordingly, there is a monetary benefit of £6,000 per individual tested. So that's about $9,000 for every patient tested. The benefit is less, but still very positive in the context of a patient with a transient ischemic attack. And in the UK, that would account for a saving of approximately £100 million per year, even after you've taken into consideration the costs of the machines and the tests. And we published a study looking at this in more detail, which informed the NICE assessment. So my main takeaway messages are that there is increasing evidence that CYP2C19 informs antiplatelet treatment in patients with stroke or a transient ischemic attack, and point of care provides an accurate, rapid alternative to lab testing when you need to make this rapid decision. I'd like to thank all the people that have worked with me on this program of work, our funders and Genedrive, the company who have developed the point of care test, for working with us on this initiative. Thank you very much.
Thank you. Thanks a lot, Bill. A lot of useful information, and I can see from questions that the interest of our audience it's really high in this regard. I wanted to really break the ice and start with one question for each of you before going to our chat. First question is from Daniel. So it's about the use of dual antiplatelet treatment in real life. We know that trials have the very rigid, strict criteria of inclusion, of exclusion, doses, but in real life the situation is very different. Patients start late, they don't use a loading dose, some of them receive thrombolysis before, and so we published some data about this, but really one would like to understand your experience in this. Do you think that this lack of full adherence to criteria from randomized controlled trials may carry higher risk, or are you more flexible and relaxed in clinical practice?
Well, we don't know. The short answer is always we don't know, because we have no randomized controlled trial answer. But I mean, the INSPIRE trial, which was very reassuring, since patients were randomized up to 72 hours. So most of the patients you see in acute stroke would be in about 3 days after stroke or TIA. So it's very reassuring to see that you can also still have benefits, including these patients in 2 antiplatelet therapy compared to 1 up to 3 days after stroke or TIA, if they are at high risk, I would say so.
Yeah. Yeah, thank you. And I also encourage all our audience also to have a look at our Readapt large study that really provides some more insights in clinical practice. My second question is for Bill. It's about, well, maybe a couple of questions. First, it's about ticlopidine. We used a lot of ticlopidine in the past. It's a thienopyridine belonging to the same category of clopidogrel. But later, for the reasons that really probably are not entirely clear, this drug was discarded, was forgotten. And nowadays, I don't think it's used anymore. At least in my country, we don't use ticlopidine, but there were randomized controlled trials showing that this drug was effective. And I think the only concern is that this drug was associated with thrombocytopenia, but this was not really so common in clinical practice. So do you think that starting using again ticlopidine may be a solution to overcome this clopidogrel resistance? This is first question. And second question, do you think it is convenient to test the patients, or a better option would be also using, for example, ticagrelor in all patients without testing, trying to have this drug approved with the indication for stroke in all countries, also now that the patent is going to expire?
So thank you for the question. So with regard to ticlopidine, I think that's a little bit difficult to know the answer to that. We still need to undertake those studies and do the trials that would compare individuals with the different approaches using a genotype guided clopidogrel approach. I think that's what we need to do to really understand if that is safe and as or more effective than the approaches that we have already. With regard to should we just use ticagrelor and not bother with clopidogrel, well, most of the benefit of ticagrelor is because we've treated individuals with clopidogrel who are poor or intermediate metabolizers. If you were able to identify those individuals and then give them ticagrelor and give the normal metabolized clopidogrel, you don't see that benefit of ticagrelor. The benefit, and then you have also that important risk, increased risk of bleeding events in individuals with ticagrelor, which I think is really important to capture. It's not just about the effectiveness, it's about the risk profile as well. And so that's what I think is that balance that we need to consider in this clinical context.
I agree.
Oh, okay, I was muted. I can see one additional question, well, even more in the chat for you. First one, is it cost effective to perform genetic testing in late presenters, those presenting, for example, after 7 days?
So we haven't undertaken that analysis, but my expectation is because so much of the benefit is in making sure that individuals are on the correct treatment within those first 3 days or so, 48 hours, 72 hours, then I would expect that a lot of the benefit would diminish the longer that the results are available. And most of the prior studies haven't been able to take that into account. That's one of the advantages of Chance 2, that they were able to make that adjustment because they had that point of care information. And when we see looking in parallel studies in acute coronary syndrome or percutaneous intervention, the benefit really does seem to be in changing that medication either through an escalation or de-escalation approach as soon as possible. And so I doubt that we would see the same benefit if we did that economic modeling at a later point in the clinical pathway.
Good, thank you. Daniel, for you, the approach to dual antiplatelet treatment in patients with severe aspirin allergy, is this possible?
Well, yes. I mean, usually you use a P2Y12 such as clopidogrel. I've seen another question if whether you choose between aspirin or clopidogrel. The absolute risk difference between these two is very, very, very low, especially considering all other variables treated, I mean, blood pressure, dyslipidemia, etc. So you can choose between either one, so either clopidogrel or aspirin. So usually if someone has aspirin allergy, I would start with clopidogrel for most of the patients.
Thank you. Bill, Does usual genetic testing counseling apply for these tests as well?
Yeah, so that's a very good question. We've thought about that extensively. We don't believe that it should do. Carrying CYP2C19 variants doesn't confer any increased susceptibility to any health problem as far as we're aware. And because these variants are so common, I'm sure that any such associations would have been identified already. The important thing to remember, though, is that CYP2C19 is important not just for clopidogrel, but for a range of other drugs. And it might be that your primary care physician would be interested in that information because it might determine antidepressant prescription or proton pump inhibitor prescription. And so finding ways to share the CYP2C19 result with other health professionals, be it through their electronic record or directly making sure that the primary care physician or the patient themselves has that information. It may be of use at a different point in their clinical care.
Thank you. Daniel, could you please clarify the indication of dual antiplatelet treatment in lacunar stroke and in TIA with the negative DWI imaging? This question is because in this population, the recurrence risk is very low.
Well, the first thing is you should be extremely sure what is really a lacunar infarction, because sometimes people do have a clinic of lacunar infarction, and you see a very small lesion, and this patient could be is a lacunar stroke. You do classify that way, but it's a branch atheromatous disease, which is a very high risk of recurrence and worsening. And if that patient, you do think that's the case, for example, you say may see a plaque in angio, CT angio or MRI, that patient has a high recurrence risk. And also, if in these patients, if you estimate based on DWI positive, or you think it's branch, or you see ABCD square high, you can use 2 platelets compared to 1 for up to 22 days, which is very safe. The problem with lacunar infarction, as I told you in the SP trial, is keeping patients with 2 antiplatelet therapies indefinitely. So that's when you do increase the risks. As I showed in all these curves, the increased risk of bleeding is mainly when you keep patients with 2 antiplatelets in the long run. In the early stage, if you keep for a very short time, the risk is very low.
Thank you. Bill, I can see that there are several questions again going into the use of ticagrelor without any genetic testing. Probably if you look at the chat, you can see that several of those who are following this webinar really question the approach about using genetic testing and thereafter giving clopidogrel. I know that we already discussed this, but given that this is a major point of interest, maybe once again setting your opinion on this.
Absolutely. I think that ticagrelor has been shown to be an effective treatment for patients with stroke, and I can understand why people would want to use that approach. And certainly, if you don't have access to genetic testing to determine the metabolizer status or genetic status of an individual, that may well be the preferable approach. However, if you can access genetic testing, then you can more confidently prescribe up to 2/3 of your patients if you're in a Northern European country, or maybe 1/3 of your patients if you're in an Asian country. You can prescribe them clopidogrel as an alternative to ticagrelor, and that comes with a reduced risk, as I stated before, of bleeding events. And I think that the equivalence of individuals who are normal metabolizers for CYP2C19, there is evidence that the use of clopidogrel is as effective as ticagrelor in those patients with a reduced risk of bleeding events, and that's why you might want to consider taking this genotyping as strategy.
Thank you. Clear. Daniel, there's a question for you about the duration of dual antiplatelet treatment in patients who have symptomatic carotid disease but cannot be treated with endarterectomy or stenting. Do you consider an extended period of dual antiplatelet treatment?
We don't know. The short answer, we don't know. I would say I would keep them for 21 up to 90 days, I would say, because it's similar to people with intracranial disease, but we actually don't know. I mean, in the studies, people were kept from 2 antiplatelets compared to 1 up to 21 days in chance, inspires, and point. And point was 90 days. I'm sorry, the combined analysis, 21 days better. But in the carotid stenosis was a criteria of inclusion in the Thalys trial, and people were kept up to 30 days with ticagrelor aspirin. But I would think about keeping it up to 90 days, but not more than that if the patient is stable. So someone just suggested, I mean, I have seen the question, someone suggested about looking for microemboli. That seems reasonable, but we actually don't know.
Yeah, and I think one additional consideration is if the patient was already on a single antiplatelet while experiencing the index event, because
Right.
in this case there's a failure of a single antiplatelet, and so an extended combination maybe can be reasonable, especially if the bleeding risk is very low and if all the other factors are already treated at the best possible. Okay, I think it's now time to close. I really wish to thank our excellent speakers, all of you who followed this webinar. It was so nice to see people joining us from all over the globe. It was my pleasure to chair this session, and goodbye everyone, and I'm handing over to Laura for the final remarks.
Thank you very much, Simona. Thank you to our presenters. Thank you to our audience who has been very engaged. A lot of questions still left unanswered, and hopefully we can have a follow-up webinar on this very soon. I just wanted to end with a reminder that this webinar was recorded, and you will find the recording link sent to you via email, but it will also be placed in our webinar page and our YouTube channel. As always, you can visit our site. You can find us on X and on LinkedIn, so you stay up to date on all of the free educational activities that the World Stroke Academy is hosting. I also want to thank once again Genedrive for supporting today's webinar, and perhaps end with an invitation, if you haven't done so yet, to register for the upcoming World Stroke Congress taking place in Barcelona, Spain this year from October 22nd to 24th. We really hope to see you there, and if not, we hope to catch you at one of our next webinars. Thank you very much. Have a nice rest of the day. Bye, everyone.
Bye, everyone.